As we move deep into this normal fetal airway, we see the sudden appearance of a cystic mass. This is congenital pulmonary airway malformation, or CPAM. It is the preeminent developmental anomaly of the lung, accounting for 95% of all congenital cystic lung diseases. The presentation of this disease creates a massive clinical spectrum. On one end, infants are born with lethal fetal hydrops. Fetal hydrops is a severe condition where abnormal amounts of fluid build up in a fetus's body cavities, often leading to heart failure. On the other end of the spectrum, patients can survive into late adulthood, completely asymptomatic. CPAM functions as a permanent structural freeze, a precise, localized halt in embryonic development that locks a section of lung tissue in an immature state forever. Because the phenotypic severity varies so widely, clinicians rely on a highly stratified diagnostic imaging pipeline. This workflow must transition seamlessly from early prenatal ultrasound measurements to definitive postnatal CT scans. This diagnostic pipeline informs the central tension faced by interprofessional medical teams, weighing the immediate physical risks of elective neonatal surgical resection against the long-term invisible dangers of conservative observation. The most severe risk of simply observing the malformation over time is its documented potential for malignant transformation into pleural pulmonary blastoma. Pleural pulmonary blastoma is a rare, highly aggressive childhood lung cancer that originates in the chest cavity. Determining the correct surgical path relies on tracing the pathology backward to its exact point of embryological arrest to accurately stratify the patient's risk. Normal fetal lung embryogenesis is defined by the rapid, highly organized branching of the bronchial tree downward into the chest cavity. This animation shows the genetic sequence driving normal development. It is regulated by specific genes, notably NKX2 and SOX2. NKX2 is a thyroid transcription factor gene, responsible for early cellular differentiation, while SOX2 maintains embryonic pluripotency and directs early airway formation. As the branches grow, fibroblast growth factors, specifically FGF10, 9, and 7, act as biological gatekeepers. They control the strict balance between cellular proliferation and apoptosis at the tips of the growing branches. Apoptosis is the standard, healthy process of programmed cell death required to hollow out the airway tubes. When these precise genetic pathways mutate or short-circuit during embryogenesis, the downward growth halts instantly, and the affected tip swells into a malformed cyst. This local genetic disruption freezes the affected lung tissue exactly at that specific embryological stage. The rest of the lung may continue to develop, but the malformation remains arrested in time. Because the bronchial tree develops in distinct stages from the trachea down to the outer alveoli, the exact anatomical depth where this developmental arrest occurs completely dictates the resulting structural subtype of the malformation. These microscopic short circuits, occurring at varying anatomical depths, are the direct biological cause of 5 distinct clinical phenotypes. Clinicians categorize these phenotypes using the Stalker classification system. This is the Stalker classification matrix, an essential 5-tier framework utilized to stratify patient severity and oncological risk. The earliest arrest occurs at the highest point in the airway, labeled here as Type 0. Type 0 CPAM originates high in the trachea or major bronchi. Because it halts development before any functional lung tissue forms, it results in an almost total lack of gas exchange, making it incompatible with life. Arrest occurring slightly lower in the bronchi results in Type 1. This is the dominant presentation, accounting for nearly 70% of all CPAM cases. The defining histology of Type 1 features multiloculated cysts lined entirely by pseudostratified columnar epithelium. Multiloculated cysts are large masses internally divided into several smaller cavities, and pseudostratified columnar epithelium is the specific layer of tightly packed cells that normally line the upper respiratory tract. Patients with Type 1 have an excellent prognosis following surgical resection. However, clinical literature tracks a rare but documented risk of these specific cysts transforming into bronchoalveolar carcinoma later in life. Moving deeper into the developing lung, an arrest in the bronchiolar regions creates a Type 2 malformation. Radiographically, Type 2 presents distinctly from Type 1. It appears as multiple small cysts that create a bubbly mass effect, lacking the large, cavernous cavities seen in earlier arrests. A type 2 diagnosis carries an immediate external implication. It is highly correlated with other severe congenital defects, such as renal agenesis and diaphragmatic hernias. Renal agenesis is the failure of the fetal kidneys to develop, and a diaphragmatic hernia is a hole in the diaphragm, allowing abdominal organs into the chest cavity. Finding a type 2 cyst requires the neonatal care team to immediately expand their screening and alter the entire care plan. Type 3 CPAM also originates in the bronchiolar region. However, as shown in this matrix, it presents as a massive, solid anomaly rather than a fluid-filled or air-filled cystic one. A type 3 lesion aggressively expands to consume an entire lobe of the lung. This creates severe mediastinal mass effect, physically compressing the adjacent healthy tissues as they try to develop in the constrained fetal chest cavity. This mechanical compression leads directly to severe pulmonary hypoplasia. Pulmonary hypoplasia is the incomplete physical development of the lungs. The lack of lung expansion strains the fetal heart, leading directly to the lethal fluid buildup of fetal hydrops. The final and rarest variant is type 4, originating at the absolute periphery of the lung in the acinar structures. Acinar structures are the terminal functional gas-exchanging units at the very end of the respiratory tree. Because development reaches the alveolar stage before arresting, type 4 histology reveals peripheral, thin-walled cysts lined exclusively by alveolar type 1 or type 2 cells. These thin walls create a high immediate postnatal risk. Type 4 patients frequently present with a sudden pneumothorax. A pneumothorax is a collapsed lung caused by air leaking out of these fragile cysts into the space between the lung and chest wall. Grave. The defining clinical caveat for a type 4 diagnosis is its incredibly strong oncological association. These specific peripheral cysts have the highest correlation with pleuropulmonary blastoma. Distinguishing between a bronchiolar type 3 and an acinar type 4 directly dictates the medical strategy. It tells the surgical team whether their primary concern is immediate mechanical compression of the heart or long-term oncologic transformation. Translating the Stalker classification from a microscopic pathology into an actionable treatment plan requires a strictly phased imaging pipeline, beginning in the second trimester of pregnancy. This prenatal ultrasound comparison shows the first phase of diagnosis. The fetal ultrasound classifies the anomaly by size to gauge initial risk, categorizing it either as a large, dark macrocystic lesion on the left or a dense, highly echogenic microcystic lesion on the right. Clinicians then utilize a prenatal MRI to rule out bronchopulmonary sequestration, or BPS. BPS is a distinct defect where a mass of non-functioning lung tissue lacks communication with the normal airway. The MRI confirms whether the lesion's blood supply is coming from the pulmonary circulation, indicating CPAM, rather than an anomalous systemic artery, indicating BPS. Once the infant is delivered, the postnatal phase begins, mandating an immediate chest radiograph for all prenatally diagnosed infants, regardless of how they may look upon delivery. For asymptomatic infants, there is a critical workflow rule. A normal initial postnatal chest X-ray does not rule out the presence of CPAM. Small cysts easily hide behind the heart or diaphragm on standard X-rays. This timeline algorithm illustrates the absolute requirement for advanced thoracic imaging. Even if the initial X-ray is clear, a CT or MRI must be performed by 6 months of age to definitively stage any occult or hidden lesions. Strict adherence to this multi-stage imaging pipeline is the only way to prevent hidden CPAM lesions from progressing unchecked into recurrent childhood pneumonias or missed malignancies. The core surgical management algorithm for CPAM hinges entirely on 2 data points: the patient's symptomatic presentation at birth and the precise volumetric size of the lesion. For symptomatic neonates exhibiting respiratory distress, tachypnea, or cyanosis, immediate surgical resection is the absolute standard of care. Tachypnea is abnormally rapid breathing, and cyanosis is a bluish discoloration of the skin resulting from poor blood oxygenation. The criteria for mandatory surgical intervention are strict. Resection is required if the lesion occupies over 20% of the hemithorax, presents with multifocal cysts, or is complicated by a concurrent pneumothorax. The clinical debate centers entirely on asymptomatic patients. Teams must decide between elective early resection of the lung tissue or a prolonged period of conservative observation. Opting for conservative observation carries specific quantifiable risks. The static, unventilated cysts are highly prone to bacterial trapping, leading to severe early childhood infections, alongside the lingering potential for malignant transformation. Elective resection is frequently chosen in older, asymptomatic children to permanently neutralize the risk of pleural pulmonary blastoma. This is especially true if the imaging pipeline confirms a type 4 classification. The surgical calculus requires balancing the immediate operative risks of performing a lobectomy on a neonate against the lifelong compounded risks of oncologic development. Because CPAM pathology spans early embryonic development straight through to later childhood, it demands a continuous, tightly coordinated interprofessional care strategy. Maternal-fetal specialists monitor the prenatal progression of the cysts. If they detect the onset of fetal hydrops, they can intervene directly with maternal corticosteroids or in utero drainage to prevent fetal demise before birth. Immediately post-delivery, neonatal nursing takes over. In the NICU, nurses are tasked with identifying subtle, early signs of respiratory distress that signal an asymptomatic patient has rapidly become symptomatic and requires urgent surgery. Following discharge, the transition of care moves to pediatricians and pediatric surgeons for long-term management and risk assessment. This cyclical continuum ensures that asymptomatic patients managed conservatively undergo mandatory annual imaging and physical monitoring, with diagnostic data seamlessly handed off between specialties. While certain subtypes present severe hypoplasia risks during development, prompt surgical resection in the neonatal period is highly curative. Despite the severe malignant potential of type 4 lesions and the mechanical compression of type 3, early genetic mapping combined with rigorous stalker staging yields an excellent overall survival rate. CPAM tests the limits of an interprofessional medical pipeline. It requires exact anatomical diagnosis, disciplined imaging protocols, and precise surgical timing to transform a fatal congenital defect into a highly manageable condition.